Hi, I am Taylor Moyes, and the population I have decided to research and engage with are individuals with eating disorders. I myself have struggled with binge eating disorders and sometimes still do, and I have many friends and family members who struggle with the same things. This topic is close to my heart. Here we go. Okay, so here's a description of the population. There are 3 main eating disorders. There are a few fringe ones as well, but these are the 3 main ones: anorexia nervosa, bulimia nervosa, and binge eating disorder. Anorexia, we've all heard of. That is extreme weight loss or failure to gain weight, intense food restriction, excessive exercise, and very distorted body image, as shown here in the image. Bulimia nervosa is binging followed by compensatory behaviors. So it is not only binging and purging, it can also be restricting calories after you've binged, abusing laxatives, or overexercising as a form of punishment. Then there's binge eating disorder. That is a large amount of food eaten quickly with no compensatory behaviors, unlike bulimia. This is the most common eating disorder in the United States. This population is vulnerable for increased health disparity because there are many stereotypes with who has an eating disorder and who develops one. So you would think a person who has anorexia is super emaciated, really thin, starves themselves all the time, but that is not necessarily true. Someone can be a normal weight and still have anorexia. Bulimia and binge eating disorder, the same thing. Sometimes people, a lot of the times, binge eating disorder, people are overweight or obese. So this stereotype can lead to underdiagnosis by providers, which means delayed treatment, and people can't get better and continue to perpetuate the health disparity. The size of the population, I was unable to find locally where I live the size of the eating disorder population. But statewide in 2011 and 2013, 4% of female students, 1.4% of male students in grades 9 through 12 in Utah public schools struggle with eating disordered behaviors and also met a criteria for low weight. Nationally, 28.8 million Americans, or 9% of the U.S. population, will develop an eating disorder in their lifetime. That is huge. Internationally, it's about the same as the U.S., about 9% of the worldwide population. So in comparison, between Utah and nationally, we are a little bit lower, according to the data I have here. So that's exciting, I guess. Okay, now we're going to go into some contributing factors. Social determinants of health. Culture for eating disorders is huge. Our culture worships thinness above all else. We claim that it's health, but it is just thin and looking good. Even if you are sick and you haven't eaten in weeks, as long as you lost weight, you're doing well. Media messages, Photoshop. The only bodies we really see, that is awesomely beginning to change, but it used to be that the only bodies we saw were the ideal image. Women are small and men are strong and big, with no cellulite, no fat. That's what we get indoctrinated with from the beginning. Dieting is also a social norm in our culture. Everyone diets. That's our life's purpose, is to diet. And I read research that one of the biggest contributors to a person having an eating disorder is that they had been on a diet. Another huge social determinant of developing an eating disorder is exposure to violence. 30% of individuals with an eating disorder have been sexually abused. So it's usually a history of abuse that perpetuates this eating disorder. Victims of domestic violence feel a need for control. They feel they can control their food intake, their purging behaviors, and NEDA says the 2 most significant factors in developing an eating disorder is trouble with family and personal relationships and history of physical or sexual abuse. So it's pretty clear there that exposure to violence is a huge deal in people with eating disorders. Some more contributing factors. Physically, people with eating disorders, people ages 15 to 24 are 10 times more likely to die than their same age peers. That's crazy. And they also have numerous health complications, which we'll go into later on the non-communicable diseases. We'll go into those a little bit later. Psychosocially, those with eating disorders are more likely to have feelings of hopelessness, more likely to be bullied at school, and have a higher rate of physical and sexual violence in dating relationships. And I would move to also say not just dating relationships, but home relationships as well. Economically, people with eating disorders inevitably have higher healthcare costs, especially if they seek treatment. And they need to deal with all the aftermath of having an eating disorder. Research even shows that those with eating disorders have lower employment rates and lower annual income. So that's a pretty big deal. In identifying the root causes, I came up with a few. So I started with the question, why are people struggling with eating disorders? Why does this happen? And I found in my research it's a combination of genetics, biochemistry, psychology, such as low self-esteem and perfectionism, culture, emphasis on appearance, fat phobia, and environment. So I learned that in sports such as dancing or gymnastics, many of the specifically females enrolled in those activities would develop an eating disorder. And sexual or physical abuse also plays into that environment. So I decided the root causes are culture, environment, and psychology. In evaluating this population on Maslow's hierarchy of needs, the needs that are met by most of the population are some physical needs. I mean, they are breathing and they are sleeping, probably. That leaves a lot of needs unmet. Specifically with anorexia nervosa, they're not meeting their nutritional needs, not food or water. Bulimia nervosa and binge eating disorder, they may meet nutritional needs depending on the individual, but they struggle to feel safe with their body. They are not healthy per se, whether physically or mentally, and as we saw in the research earlier, potentially they will not be employed. There won't be security in employment. So I would say the anticipated function level is low. Individuals with eating disorders may be stunted in their ability to thrive in relationships with self-esteem and self-actualization. So it's obvious that physical health is an issue with eating disorder populations, but without the top 3 tiers of needs met, mental health will suffer as well. So we're not just talking about physical health here. Mental health is going to be struggling. It may be difficult for these individuals to seek treatment for physical needs if they don't feel they deserve to have a better life or their problem solving is lacking. Communicable diseases for anorexia nervosa, it's from my research I learned they have a lower risk of reacting to bacterial or viral infections, leading to lower rates of diagnosis, leading to increased morbidity and mortality related to those infections. Cytokine and immune system changes have been found in those with anorexia nervosa. Researchers correlate these immune changes with nutritional deficiencies. So, to decrease the incidence of these diseases, nutrition must be restored. And as far as non-communicable diseases or infections, multi-organ failure, osteoporosis, anemia, low blood pressure, heart damage, infertility, and many more, actually. To prevent these diseases, treatment for the eating disorder must be sought early. Malnutrition over an extended period of time is going to increase the incidence of these and the severity. On the other hand, if we restore nutrient balance early and fat source early, we will at least help the disorder not continue, or the disease not continue, and maybe not get worse. Self-harm is pretty common with those with eating disorders. Of women hospitalized for an eating disorder, 36.8% also self-harmed on a regular basis. Interestingly enough, self-harm is not just cutting, which is what I picture. Laxative abuse, excessive exercising, and purging can also be classified as self-harm behaviors, which are all common in those with eating disorders. Treatment for self-harm includes cognitive behavioral therapy, dialectical behavioral therapy, and medication. Those with eating disorders have a higher chance of lifetime intimate partner violence, as we've seen in past slides. To mitigate this harm, the solution is for the individual to seek treatment and safe haven from the intimate partner violence. And those are my references. Thank you very much.